When we think of dialysis, we often picture a machine quietly doing its work. A lifeline, certainly. A routine, absolutely. But within this routine lies a complex and dynamic process. This procedure, which sustains millions, is a marvel of modern medicine. It removes waste and excess fluid when the kidneys can no longer do the job. Yet, this life-saving treatment is not without its risks. Connecting a human being to an external circuit creates potential for sudden complications. These are not minor hiccups. They can be true medical emergencies. Vigilance is our most powerful tool. Recognizing and responding cannot be overstated. A patient's life can hang in the balance. The window is often seconds, not minutes. A stable treatment can pivot to crisis with little warning. This is why every team member, nephrologist, nurse, technician, must be a guardian. Understanding the why is the first step toward mastering the how. Empowering professionals with knowledge and confidence turns potential tragedy into successful care. Disclaimer: this video is intended for educational purposes only and must never be used as medical advice. Please consult your doctor about any personal health concerns. To understand emergencies, we must appreciate the profound physiological changes during treatment. Over a few hours, dialysis does the work kidneys usually do over days. This involves rapidly removing fluid, ultrafiltration. Imagine draining a swimming pool too quickly. Removing fluid faster than the body can replace it lowers blood volume and blood pressure. This hypovolemia is a primary trigger for intradialytic hypotension. Dialysis also alters electrolytes, potassium, sodium, calcium, important for nerves and muscle. Rapid changes can provoke muscle cramps or dangerous arrhythmias. Circulating blood outside the body introduces mechanical risks. Air embolisms may occur if air enters the circuit. The blood interacting with synthetic surfaces can rarely trigger allergic inflammation. Understanding these stressors helps anticipate and manage emergencies. Rapid corrections can cause problems. Speed and balance matter. The biochemical environment shifts quickly. Vigilance is essential. Next, we will examine the common complications seen on the dialysis floor and how to spot them early. In a dialysis unit, a few complications appear more frequently than others. The usual suspects. The most common is hypotension, low blood pressure, often a direct result of rapid fluid removal. Symptoms: dizziness, fainting, nausea. Signs: vital organs may be underperfused. Another critical but rarer event is an air embolism, air entering the bloodstream. Even a small amount of air can block blood flow to the heart, lungs, or brain. Consequences range from stroke to respiratory failure or cardiac arrest. Modern machines have air detectors, but human or mechanical failure remains a risk. Muscle cramps are common, painful but usually not life-threatening. Allergic reactions can escalate quickly from itching to anaphylaxis. Cardiac arrest is the most urgent scenario. Many dialysis patients have pre-existing CV disease. Have an AED on hand and ensure staff are BLS/ACLS trained. These preparations are an absolute necessity for patient safety. Hypotension, air embolism, cramps, allergic reactions, and cardiac arrest. Know the signs, anticipate the steps. Quick pause. If you enjoy this video, please take a second to like and subscribe. Also, check the description below for links to additional useful resources. The key to managing any emergency is to catch it early. The body often sends subtle distress signals first. Listen to the patient: dizzy, lightheaded, nauseous. Yawning, pale or cool, clammy skin. These are red flags. Slurred speech or blurred vision can signal inadequate cerebral perfusion. Pair symptoms with objective data. A falling BP is the clearest sign. Air embolism signs are sudden: gasping, chest pain, cough, extreme anxiety. Look for cyanosis and inspect the venous bloodline for visible air or foam. Itching, flushing, hives, wheeze, throat tightening. Suspect an allergic reaction, especially after a new dialyzer. Shortness of breath and wheeze require immediate attention. Crushing chest pain, pain radiating to arm/jaw/back, acute shortness of breath, think cardiac. Any sudden loss of consciousness and absent pulse equals sign cardiac arrest. Continuous monitoring and frequent checks are vital for early detection. Early warning callouts: pale skin, yawning, dizziness, slurred speech. Catch them early and act. Let's walk through scenarios to see how emergencies unfold in real time. Imagine you are a technician caring for Mr. Henderson, 2 hours into treatment. You walk by and notice he has stopped reading and looks pale. You ask, "How are you feeling?" He says, "A little woozy. My stomach feels queasy." His skin is cool and damp. Check the machine monitor immediately. BP is 85/50. Classic hypotension presentation. Now consider Miss Garcia, starting treatment with a new synthetic dialyzer. 15 minutes in, she says, I feel really itchy and hot. Small welts form, and she begins to wheeze. Elsewhere, an air detector alarm sounds on Mr. Chen's machine. You and a nurse rush over. Mr. Chen is gasping, and you see frothy bubbles moving toward the patient. Potential air embolism. Something is wrong with my mom. You race to Mrs. Davis. She is unresponsive, ashen. Check pulse and breathing immediately. No pulse, not breathing. This is cardiac arrest. Initiate code blue. The unit shifts into code mode. Gloves, crash cart, compressions, defibrillator. Coordinated action is required. Your actions in the first 5 minutes are the most critical. Have a clear, systematic approach. Assess the patient and the machine. Place the patient in Trendelenburg, head down, feet up, to improve cerebral perfusion. Decrease or stop ultrafiltration to prevent further fluid loss. Call for help. Calmly state the issue and location. Decide quickly if a saline bolus is needed to increase intravascular volume. Administer saline into the venous line and monitor BP every few minutes. For air embolism, clamp the venous bloodline immediately. Position left lateral decubitus with Trendelenburg, Durant's maneuver. Do not return the blood from the lines. Administer high-flow oxygen and activate emergency response or call 911. Disconnect and sequester the extracorporeal circuit for investigation. In cardiac arrest, call a code, start high-quality chest compressions immediately. Apply the AED/defibrillator and follow ACLS sequence with a designated team leader issuing clear commands. During an emergency, the environment quickly becomes chaotic, and patients are often terrified. Your words and demeanor are powerful tools. Therapeutic communication is a clinical skill. Approach calmly, make eye contact, speak clearly, explain what is happening and what you are doing. For example, Mr. Henderson, your blood pressure is a little low right now. This is common, and we are going to take care of it. Give a concrete action. Take slow, deep breaths. It reduces panic and helps physiology. Remain calm yourself. Your composure is contagious. With the team, use concise, structured updates. S-bar or closed-loop models prevent errors. Say, patient at station 4 is hypotensive, BP 85/50. Trendelenburg, UF off. Wait for acknowledgement. During a code, one person leads. Give loud, clear commands. Sarah, get the crash cart. Tom, start compressions. Assign someone to reassure other patients. We have a medical emergency. Please stay calm. After the event, debrief, document, and communicate the outcome to family and patients. Clear, compassionate communication is as essential as clinical skill. It calms, builds trust, and aids recovery. Knowing the steps is one thing. Executing them under pressure is another. Regular hands-on simulations build muscle memory. Run a monthly mock code for cardiac arrest and quarterly air embolism drills. Practice identification, calling for help, assigning roles, compressions, and AED use. Use stop and fix during training for immediate correction of technique. Debrief, what went well, what to improve, did everyone know their role? Rotate learners through stations, hypotension, air embolism, access disconnection. Use symptom cue cards and mannequins with physiologic changes. Practice two-channel communication. Reassure the patient while giving SBR to incoming staff under simulated distraction. Record drills, capture timestamps, and document lessons learned. Combine hands-on drills with continuous education and guideline reviews. Foster a culture where staff discuss what-ifs and report near misses without blame. Practice until you can't get it wrong. That confidence saves lives when adrenaline hits. In the final analysis, patient safety doesn't rest on one person or the machine alone. It requires teamwork, preparedness, and shared vigilance. Small habits, double-checking connections, listening to a patient's complaint, prevent escalation. Preparedness is not a one-time course. It is a daily discipline. Technical skill plus human compassion, a reassuring touch and clear explanation, build trust. A confident, cohesive team turns chaos into control. Success is built long before alarms. Practice, huddles, and debriefs form the backbone of safety. Behind every alarm is a mother, grandfather, or friend. Our duty is to protect them. Teamwork and preparedness do more than manage complications. They save lives. Prepare with rigor. Practice with purpose. Keep the dialysis chair a seat of life. If you enjoy this video, please take a second to like and subscribe. Also, check the description below for links to additional useful resources.